I want to welcome you to one more webinar for the Post-Operative Pain Study results, known as the POPS study. So I'm Joana Cruz. I'm with the National Dental Practice-Based Research Network, and I'm the Assistant Director for the South Central region, but I'm also the Director of Communication and Dissemination. So let's get started. We are joined today by Dr. Walji, Dr. Tungare, and Dr. Shirodkar. But I would like first to welcome all of you here and also welcome our presenters. But let me tell you a little bit about our presenters. Okay, first we have Dr. Walji. He is the principal investigator for the POPS study, and he's interested in investigating how informatics approach can solve clinical problems and improve the quality and safety of oral health care. He serves as a professor and chair in the School of Biomedical Informatics at UT Health Houston, and also at the director of the Texas Center for Oral Health Care Quality and Safety at the UT Health Houston School of Dentistry. You are very welcome here, Dr. Walji, and we are really looking forward to hear about the results for POPS. We also have Dr. Tungare. She will be talking about the data analysis that was conducted with the POPS study. She's a dentist and public health professional interested in integrating public health and health informatics research methods to advance oral health care research. She is an assistant professor at the UT Health Houston McWilliams School of Biomedical Informatics, and she will be presenting about the results. Joining Dr. Tungare and Dr. Walji, we have Dr. Shirodkar. Dr. Shirodkar participated in POPS. He enrolled participants, and he will give us feedback on how was his participation, but also how was POPS important for his clinical practice. He's a board-certified endodontist, a diplomate of the American Board of Endodontics, and member of the Scientific Advisory Board for the Journal of Endodontics. He practices at Advanced Clinical Endodontics in Spring, Texas. So he's from the Southwest region from the network, and he works closely with Dr. Rama Mungia and David Cochran. So we are very excited to have you here, Dr. Shirodkar, and it seems that you completed endodontics residence at the UT Health San Antonio, right? And you won first prize in a 2022 AEA annual meeting. So, yes. And you were a clinical assistant professor at the UT Health San Antonio. So we have here UT Health Houston and UT Health San Antonio working together on POPS, which is very exciting. Dr. Walji, what do you have to tell us about the study results? And please remind us, what is POPS study first?
Absolutely. Well, first of all, I want to thank you, Dr. Cruz, and the whole network for the opportunity to be able to present some of our results on behalf of the whole POPS study team. So we're very excited to be able to share that. Maybe let's start with, why did we even engage in this study to begin with? So along with my colleagues, Dr. Elizabeth Calendarian, who's an oral surgeon and dean at Marquette, and Dr. Joel White, who is a general dentist at UCSF, we had done several years worth of work on looking at patient safety issues and adverse events in dentistry by mining data from the electronic health record. And one of the most frequent adverse event types that we found was post-operative pain. And so that really sparked an interest in us to see, can we study that a little bit more, especially prospectively? At the same time, we had connected with Dr. David Holmes, who's a periodontist, who actually had built a startup company and this very unique mobile health app for helping follow up with patients after care. So taking those kind of two ideas together, we conceptualized the POPS study, which was to kind of paint a real-world portrait of post-operative dental pain after common dental procedures. And thanks to encouragement by our colleague, Dr. Brad Rindle from the Midwest node, he's the director there, he suggested using the National Dental PBRN to study this. And what better place or what better platform to use a network like the National Dental PBRN that covers the entire country and real world practice to be able to do this. So we had three main goals of this project. The first one was to characterize the post-operative pain experience for common dental procedures. And by pain experience, we mean the post-op pain intensity of patients, as well as interference of pain with various daily activities. We were also very, very interested in learning about the pain management strategies that dentists had in terms of managing that experience, but also how did patients feel about that as well. And then thirdly, as an informatician, especially, we're very interested in technology and the use of the mobile health, not only to collect this data, but also to see how it could be useful for dentists in practice as well. So we were very interested in looking at both the usability and acceptance of this platform too. So we're very fortunate to be able to have 144 dentists who participated in this study. So thank you to all of you who are listening today who participated, and those of you who may not be on the call today. But you are responsible for recruiting over 3,100 patients, which is pretty incredible. I want to talk a little bit about the technology, which I think is one of the unique aspects of this study. So the way it worked is that after the practitioner identified a patient who agreed to participate, they entered their name and phone number in the mHealth platform while they were there for that dental procedure that day. Immediately, the patient would get a text message on their phone on day 0, which was what we call the day of the visit of the procedure, and they would fill out the demographic information as well as report their post-op pain. And then subsequently, the day after, 3 days, 5, 7, 14, 21 days later, they would get a text message at 9 o'clock in the morning, and you can kind of see the experience on the left-hand side where we asked them a series of questions regarding their pain, any swelling, what meds they were taking, whether they had any interference with various activities, how satisfied they were with the pain management plan, did they use any non-medication alternatives, and then interestingly, if they had any questions for the dentist. So not only were we trying to gather the data, we were very interested in seeing how that data may actually impact the post-operative plan. So what would happen is that, if the patient's pain level was a certain level, let's say 7 out of 10, they would actually get a notification just to alert them that, your patient has reported this amount of pain. Or if they have a question, they were also notified. So we're very interested in seeing whether the practitioner actually used the chat feature or made a phone call to see if the platform could actually help with that post-operative experience. Okay, so now this study was very in-depth in terms of both planning and execution as well. And so we're very fortunate to work within this very experienced network that provides great support, both from study setup, how do you plan a study? We did a ramp-up phase where essentially we had some pioneering dentists who agreed to participate early on so we could work out any kinks. And then we continued on with the full study, which we finished about a year or so ago. And then over the last year, we've been analyzing the data. This is the first time we're officially sharing the final results. So we're very excited to do that. And then a publication will be submitted based on the data that you've seen very soon as well. Okay, so I'm going to go over some of the high-level demographic results, and I'm going to hand it over to my colleague, Dr. Tungare, who's going to go through some of our research questions and what we found. But we had about 85% of those 3,100 study participants, the patients, where we could use their data, which I think it was really good. And so this is what we found. About 56% of the participants were women. They were predominantly Caucasian, although we did have about 15% who were African American and 6% Asian. The mean age of the population was about 50, and about 13% of the patients were Hispanic or Latino. In terms of where they lived, we had a nice mix where 55% were suburban, 27% were urban, and 18% lived in rural areas as well. In terms of household income, we had 65% of the participants who had over $50,000 in household income. Notably, 33% actually had quite high income, over 100,000 as well. The participants also had a diverse range of education, where 71% had some college or associate degree or higher. In terms of the insurance status of the patients, most of them, 63%, had private insurance, about 20% had some sort of public or government insurance, and nearly 18% had no insurance as well. And then the number of members in household was about 3 in terms of the mean. Okay, so as I mentioned, one of our main goals was to characterize the pain experience across different common dental procedures. While we didn't have a specific target in mind when we set up the study, we were hoping to get a nice mix, and I think we did. 50% of the procedures that patients underwent were related to either simple or surgical extractions. The next highest was non-surgical endodontic procedures. And then you can kind of see the other types of procedures that we had as well. So this was a nice selection where we could get a lot of good information. And Dr. Tungare is going to go over the pain intensity for those procedures. We were also interested in the post-management strategies, especially medication strategies. So we asked a series of questions to the patients in terms of the types of medications they took. We found that about 16% of patients reported never taking any medication post-operatively at all across that 7-day period. And you can kind of see on day 1, that was lower. Obviously, only about 12% had no medications or pain medications, and that increased to about 40% on day 7. Another area that we were particularly interested in, especially with the opioid epidemic, was what percentage of patients are actually taking opioids. And we found that 10% of the patients reported taking at least one opioid medication across that 7-day period. And you could see that on day 1, about 6.6% of patients reported taking it, all the way down to 2% on day 7. And we did have a lot of patients taking non-opioid analgesic medications. So about 78% nearly reported taking at least non-opioid medications on at least one of those days, with a high of 65% on day 1 and a low of 30% on day 7. Okay, so I'm going to now hand it over to my colleague, Dr. Tungare. Also want to thank her because she's done a tremendous amount of work on the data analysis along with our statistician, Dr. Young.
Thank you, Dr. Walji. Hello, everyone. I'm Sayali Tungare. Thanks, Joanna, for the introduction. I will be presenting to you all the interesting findings that we have so far from the data analysis that we conducted in this study. Moving on to the first outcome of interest that we had, it was the patient's pain intensity. So we asked the patients throughout the post-operative period about their pain intensity in terms of a pain score. On a scale of 0 to 10, they rated what their pain score was on that day. And what we found out over here, you'll see a graph of how pain changes over time by different procedure types. Overall, we did see that the pain levels decreased over time, but let's look at this graph in the level of detail that we have. So on the left, if you see, this column has all the procedure types, and each of the following columns is the day of the data collection point. So day 0 was the pre-operative pain that they came in with to the practitioners, and then we have information from day 1 through 7 on the post-operative pain experience. how you would read this is, for example, for surgical extractions, patients came in with a pain on an average of 3. So the green dots that you see across the graph are the mean or average scores from all the patients that reported, and the gray bars represent the range of responses that we received, so the range of scores for these patients. And you see that the pain on an average did go down for most of the procedures, except for surgical implants and surgical periodontal procedures, wherein the patients came in with little pain, but then the pain increased post-operatively on day 1, and then it took them up until day 7, or maybe sometimes more, to get the pain levels below or near 0 almost. And then on the contrary, we do see endodontic procedures, be them pulp treatments or non-surgical endodontic root canal treatments. All these procedures had one of the highest pain intensities pre-operatively, but then we see a sharp drop on day 1 in the post-operative pain intensity, and that goes down near 0, very minimal pain experienced by day 5 for these procedures. Now, in terms of what different factors were associated with the pain responses, we would like to highlight some patient factors or clinical factors or procedural factors that were associated with higher pain levels or higher likelihood of reporting pain intensities. So, for example, if a patient is younger, they experienced higher pain than those who were older. As you progress through age, higher or older age groups had lower pain levels for any procedure type. And all of this analysis that we've conducted, we have adjusted the analysis for multiple patient and procedural factors. So after adjusting, this is what we saw. The post-operative swelling, if that is present, then patients are likely to experience higher pain levels. And in this study, those patients who reported higher pain levels also reported taking some kind of pain medication, be it opioid or non-opioid analgesics. Then there was a group of patients who experienced moderate or severe pain, be it on day 1 or 7. This pain, we categorized it as moderate or severe if the pain was higher than 4 and up to a 10 on the scale of 10. 4 to 6 was moderate pain, 7 to 10 was severe pain. And they reported moderate or severe pain when more severe preoperative pain was present on day 0. Female patients had moderate or severe pain more than male patients. And then patients who had their annual household income below $50,000 reported higher severities of pain experience. And then we move on to this in-depth analysis presenting to you odds ratios, which I'll simplify and explain using this graph. So what you see here is on the left, there are all the procedure types. And on the right, the x-axis shows the odds ratios, which is the likelihood of higher pain intensity that a patient would experience. So when we look at the different procedure types, and through these 3 pain severities, blue representing the mild, orange representing moderate, and then the red triangles representing severe intensity, we see that all non-endodontic procedures. So our baseline was endodontic root canal treatments. So those and endodontic pulp treatments, except for those, all the other more surgical, more invasive treatments tend to have higher post-operative pain. And then specifically in those, when a patient undergoes multiple procedures, those could be a combination of simple and surgical extraction, or an implant and a periosurgical procedure. those patients have experienced more severe pain than other procedure groups. This was followed by other surgical procedures, the periosurgical, implant surgical, and extraction surgical procedures. So apart from the pain intensity, what we were also interested in learning was how pain interfered with the daily life for patients. And in terms of interference, we had asked the patients questions on 5 different measures or constructs. So these are the 5 different measures that you see in these columns. We asked them questions about how pain interfered with them performing daily activities like walking, getting out of the bed, performing regular tasks, going to work, eating food, falling asleep, staying asleep, and then speaking. On the left, you will see we have the interference categorized by mild interference, moderate interference, and severe interference, again on a scale of 0 to 10. Mild was 1 to 3, moderate was 4 to 6, and severe was 7 to 10. And based on the different procedures that were performed, we saw these results. So the orange squares indicate that the results were statistically significant in terms of the differences that we see. So let's look at the yellow highlighted sections and what they represent. So it means that eating food and speaking, especially with procedures that were more surgical in terms of extractions, implants, or perio, those procedures show higher pain interference post-operatively during the 7-day period with eating food and speaking. When we look at performing daily activities, there was mostly mild interference experienced with these procedures, and no moderate or severe experience can be said with confidence because the intervals over here were out of the chart, and we think that the most interpretable result is that we would see mild levels of interference with performing daily activities. For falling asleep and sleeping asleep, we found little to no interference at all, except for maybe a couple of procedure types that would be associated with a little or mild interference with falling asleep. But overall, there was no pain interference as such. And looking at specific procedures, we do see that endodontic pulp treatments and the baseline category, which is endodontic root canal treatments, do not have any post-operative pain interference, be it mild, moderate, or severe, with any of the 5 different measures of interference. Next, we also asked the patients about how satisfied were they with the pain management strategy and protocol that was used. This was scored really well. So what we see here is patients answered that they were extremely satisfied with the pain management protocol or strategy that was followed by their practitioner, and felt that they were very much allowed to participate in the decision-making of the pain treatment and pain management as much as they wanted to. And all of this, again, analysis was done while adjusting for multiple patient and procedural factors. So lastly, we also looked at this mHealth platform, like Dr. Walji was initially referring to. We were interested in understanding you practitioners and the patients who use this platform so extensively during the study, be it right from recruitment of the patients until responding to their messages, monitoring their pain responses, all of that. How was your experience and the patient's experience in using this platform? So first, we look at the patient usability feedback, and overall, we asked them 10 questions on the system usability scale. These are 10 statements, and they answered them in terms of agreement with the statement on a Likert scale of 1 being strongly disagree to 5 being strongly agree. And these questions are worded, 5 of them are worded positively and 5 are worded negatively. So a disagreement with a negatively worded question would mean that they perceive the platform positively. So overall, after analyzing this data statistically, what we found that we have a total score of 90.2 over 100, which is an excellent score. So the standardized way of interpreting this scores says that above a 75 is an excellent score, which indicates very high level of usability and ease of use, and that it meets the needs of the users. So that is what we found from the patient side. And then for the practitioners, what we see here is a different scale that we used, a different questionnaire that we used. This UTOT instrument was used for assessing the practitioners' feedback about the mHealth platform. And it is measured across all of these different constructs, right from their performance expectancy to their effort expectancy, translating into behavioral intentions, and finally the use of that. So what we found in general through all of our analysis was that there was in general a very positive attitude towards using the platform, and it was perceived as useful, easy to use. It did improve the practice in terms of patient follow-up for all of our practitioners, and they also indicated that if support is provided in terms of resources or through staff help, and along with their confidence in using technology itself, that would lead to further use and continued use of the health platform. We did not see any anxiety being reported in using this platform in general, meaning that the practitioners were not apprehensive or intimidated about using this technology in general. So going over the practitioner interviews at the end, we interviewed about 43 practitioners who had participated in the study. Once they had completed the recruitment of all of their patients, we checked in with them to see how their experience was, what we could improve, what kind of feedback they had for us, how this study impacted their practice. And here is what we heard from them. And we are highlighting some of the themes that came across in these practitioner interviews. So first, the practitioners highlighted their experience with the mHealth platform. Overall, it was very positive. Practitioners appreciated the real-time information that they got on the patient's post-operative pain intensities and interference. They thought that they could, manage the patients much better. They were engaged a lot in the care provided, and that some patients, some practitioners, especially those in smaller practices, did find that the mHealth platform reduced burden in terms of effort and time that was needed for follow-up of these patients. In terms of how it impacted their practice, practitioners reported that they had happier and more grateful patients. This was received either through the text messages through the app, or this was received in terms of phone calls, or when they came in for any scheduled visits. So what patients said was that they felt that there was a sense of better care because they were directly interacting with the practitioner. Even having them accessible, even if they didn't reach out directly, made an impact, and they felt a difference in the sense of feeling that care being provided. Practitioners were able to modify the pain strategies as needed. So if someone was in more pain, they could switch medications. If pain had gone down by day 3, they would inform that pain, there was no need to take any further medications. So those kinds of modifications could be made. They could schedule follow-ups better. If they saw that a patient had recovered very well and did not need to be scheduled for a routine follow-up that they would have had, they would not schedule them or schedule someone earlier if they had a complication. So this also increased their confidence in using the platform, as well as it increased their confidence in terms of expecting better what patients would feel post-operatively and educating the patients as well. With all of that being said, there were, of course, many suggestions that were also provided to us for improving this mHealth platform. And one of the main ones that came through from you all was integration with patient management systems. So whichever EHR systems you had, you would appreciate if the platform is integrated with that. Practitioners also suggested that instead of going through the 21-day follow-up period, you could have personalized follow-up durations. And once a patient is out of pain, you don't need to follow up anymore. They would appreciate the possibilities of send post-op instructions through the platform, as well as receive images if there are any complications that are present, and they would like a patient to take a picture and just send it to them. They also would have liked if there are any auto-generated responses that they could just push through instead of having to type an answer for each of the patient questions. And lastly, when we talked to them about future use of this platform, they did perceive this platform positively and said that they would want to use it in the future. But then there were factors that would also influence the future use, and those were considering the cost of this service, if monitoring by the staff could be included, and of course, the integration with their scheduling and EHR systems. So with that being said, we completed the formal analysis that we had set out to conduct. But through our practitioner interviews and our previous webinar, we got excellent feedback on what other analysis we could conduct and what practitioners are actually interested in understanding. So to cover that, we conducted a couple more analyses, and we are going to provide a preview of that. We are still working on those analyses. So the first one was comparison between the pain that was predicted by the dentist and then the pain that was reported by the patients. So dentists were interested to understand how did that differ? Were we accurate in terms of predicting the patient's pain? And what we see here in this graph is everything in blue is when the dentist over-predicted pain. Everything in orange is when the dentist under-predicted pain, and the beige colored bar means that prediction was accurate. The patient and the provider said the same thing. So to give you an understanding of what this means, we saw that dentists for the most part did overestimate pain that was experienced by the patient, and we saw a mean difference of at least 2 points. So if you were to rate it on a scale of 10, the dentist would rate it about 2 points or so higher. Then if we look at specific days, on day 1, we did see that even if we consider plus or minus 1 from the patient's score, there was about 25% accuracy in predicting the correct amount of pain that the patient would experience, but then 55% of pain over prediction was seen. The dentist perceived that the patient would feel more pain. And this improved as the days went by. So when dentists reported days 7 to 21 pain prediction, we saw that there was higher prediction accuracy for long-term pain. So we have about 80-ish% accuracy, which is quite a bit improvement for long-term pain. Second, we looked at which medications were prescribed by practitioners and what was taken by the patients. And here we have the results where non-opioid analgesics aligned. Practitioners prescribed 81%, and then the patients took about 7%. But in terms of opioid analgesics and antibiotic medication, we see that there is a higher patient-reported use of the prescription medication, whereas the dentist didn't really prescribe it, or dentists didn't report to us that they had prescribed this medication. And this is after considering whether they switched during the period or not. So this is a difference, a big difference that we see for the prescription medications. And with that, we are done with the study results. I would turn it back to Dr. Walji to go over the acknowledgements.
I just want to spend just 30 seconds just thanking everyone. So this was a yeoman's effort, literally, for this study, and so many people were involved. So I really want to first thank all of you, the practitioners, for participating. It's just been an incredible collaboration, and obviously your patients that you're able to recruit, without which, we wouldn't have been able to do this, but that's also the group that we're trying to serve. Also want to thank the whole network, led by Dr. Gilbert, all of the different regions, as well as Dr. McBurney and, the Data Coordinating Center. Also really want to thank NIDCR. We were very fortunate to have Dina Fish and Margie Grisius provide support and advice to us throughout the process, and funding from NIDCR. And then lastly, our research team. I won't read everybody's names here, but it was an excellent group to be able to work with. So just thank you to everyone.
Thank you, Dr. Walji, and your group for conducting the study and presenting today. Dr. Tungare, you did a great job explaining the study, and Dr. Walji introducing it to us. We also had practitioners who participated in the study that would like to share their experience with us. Dr. Gautam Shirodkar, welcome here. I'm so glad that you were able to join us today. And I see that you've been in clinic, as most of our attendees probably are now. But tell us, how was your experience doing POPs?
All right. Thank you, Dr. Cruz. Thank you for inviting me as a panelist for this webinar. Excellent work, Dr. Walji, Dr. Tungare, and IDCR. This is commendable to have such huge sample size, performing analysis on such big data, and then coming out with real excellent results. What motivated me to be a participant in the study was it was more patient oriented. So these were patient reported outcomes. And I'm particularly interested in pain research, especially those involving pain resolution. So this was my basic reason why I participated in this study. And trust me, recruiting patients was really easy. I didn't have to convince my patients enough to be a part of this study. They were ready to be a part. So what really helped me was the way we recruited patients. The mHealth platform, or the FollowApp, the app which patient used, that was really nice. Everybody loved using it. A lot of my patients told me, why don't you use it for your practice? And yes, we did consider using that app. Those patients really felt that we cared for them because they could reach out to me. I could get back to them very easily. So I could modify the pain protocol if needed. So that was really nice. That was what my patient really enjoyed.
Dr. How does the results that you saw today compare to your experience with your patients in your practice? I think you're going to answer that, right?
Yeah, I'm coming to that. So being an endodontist, I'm really happy to see that Endover is able to resolve pain. That's what we strive to do. That's what we do. And that's our biggest selling point. So I'm so happy to see Endo was the baseline to which everything was compared to. I was also happy to see that the opioid prescriptions were much, much, much lesser than non-opioid analgesics. So that's always the first line of pain protocol for us, be in my training or my practice. What I also saw that there is really very minimal need to prescribe an opioid or an antibiotic just for pain. We're still not sure if antibiotics help in pain resolution post-operatively. Of course, I mean, unless if there is an infection. But that's one of the promising results which I see, which go in accordance to the current publications which are coming out of, antibiotic and opioid prescriptions. Yes, we do tend to over-predict pain. And I don't know, it's a food for thought. I don't know if we really are over predicting, and that's one of the reasons why we are prescribing more pain medications post-operatively. But this is really a point for us to think where what should be done in terms of short-term management of pain, especially after any procedure. So coming to that's my basic understanding of the results. Like, I'm glad we are helping our patients. I'm glad patients are happy with whatever we are doing, and studies like this are a motivating factor for us to perform well and to improve our clinical efficiency and clinical pain management protocols.
Thank you so much for sharing your experience and your feedback regarding the results, Dr. Shirodkar. We always
Thank you.
to hear from our practitioners. And talking about that, we have one more practitioner that would like to share about his participation in the POP study. Dr. Peter Loomer, would you like to join us and share a little bit about how has been your experience and how do you see the results compared to your experience?
Yes, thank you for the opportunity to share. I think the way we communicate with our patients, we see in medicine, often there's an app and people can can send a message to their doctor. So I think this is sort of a way, an important way that our dental patients can communicate with us. I think that timeliness is what patients really appreciated. And I know Dr. Holmes has been working on that app for many, many years. I'm glad to see that the most practitioners and patients felt it was very usable and really an advantage for communication. I think that really, to me, that's one of the highlights of the study, was really that this is a way of communicating with our patients. We tend to, as Dr. Shirodkar mentioned, we tend to over-medicate maybe a little bit, but we're kind of trying to prevent the patient from having pain. And I certainly, in the surgical procedures where there's soft tissue and hard tissue manipulation, we know that we're going to cause some inflammation in the tissue. So often medications are prescribed prior to the surgery starting or just right after the surgery starting. So sometimes we preventively medicate as well. So I think there are some nuances of how people treat patients having surgery, but we always want the patient to have the least amount of discomfort. So I think the results aren't really surprising, but they're kind of validating what we're doing. But the use of the method of communication here, I think, is really a way to advance our patient management.
Thank you, Dr. Loomer, for sharing your experience with us. But I would love now to entertain some questions. So where do you expect patients are getting opioids and antibiotics not prescribed by the dentists? That's one question. And I would open it for our panel to answer. And together with that question, we have in the same person asked Dr. Kuja that what kinds of survey did you use for the pain interference? Is it a validated survey?
Yeah, yes. Thank you for that question. So I'll start with the second one. Yes, we did use some validated instruments. NIH has this great resource called PROMIS on various types of patient-reported outcome measures. So we did use and some of our questions came from there, as well as the APS-POQR from the American Pain Society. So in the paper, I think we have one paper already out, a protocol paper that references those that we can share with you. On your first question, we don't know what's happening there. So that's definitely a very interesting finding. Why is that discrepancy between what patients are being prescribed and what they're reporting to take? Obviously, we can speculate, but we don't really know. Is there some issue in reporting, or is there leftover medication people are taking? Like I said, we can speculate, but we really don't know.
That's an interesting finding that deserves more exploration, even for a future study. We have one more question about what was the pain protocol that was followed?
Yeah, I'll also invite Dr. Tungare to also chime in as well on these questions. But no, so we didn't have the dentist follow a specific pain protocol. No, this was kind of, we left that to them. So our contribution in the study was to be able to capture the pain reported data kind of in this natural environment. They would then document the pain strategy that they used on day 0. We collected that data 3 weeks later if they made any medication management changes.
Yes, that is exactly how we did it. We wanted to follow the routine practice as much as possible and see what happens in the real world dental practice in the network.
And then, Dr. Tungare, we have an interesting question here. It's that a clarification. Did you find more pain in the younger population? I think this might be a new finding, but I would be interested to learn if you can confirm that that was what was seen in the data.
Yes, yes. So that's what we saw. We categorized age group. Like you saw, we have a mean of about 50 years, or average patient age was 50 years in the study population that we had. But we had a good mix of patients in each of the age categories. So we divided the age groups into different age categories, 18 to 25, 26 to 35, and so on, until 65 plus. And what we did see is that there was a decreasing trend as the age increased. So an increasing age decreased the pain intensity. And that is how we were able to predict that younger patients reported higher pain intensities in this study.
Okay, keeping in mind that those are patients 18 and older.
Yes,
we're not talking about children.
all adult patients. And this was adjusted for the different procedure types that are done, as well as the medications that were taken and other socio-demographic factors that were associated with the patients, along with their pre-operative pain intensity.
Okay, we have a few more questions here in the chats. So what were the use of topical anesthetics, such as lidocaine, for pain control, and if that had an effect later on pain level, post-op pain?
Right. So in terms of anesthetics, because there is some evidence out there about use of long-acting anesthetic and reduce post-operative pain experience, we did collect that information on long-acting anesthetic use, and we did not find any association between use of long-acting anesthetic and any pain intensity outcome post-operatively in this study.
This is quite interesting. I was really interested in that question because, yes, I have heard about that too. And it's interesting that this study did not find that effect.
Yes.
I hope you can publish that and discuss those findings.
Yeah, we included it in the model and it didn't show any statistically significant associations with the variables. So, and this is for pain, post-operative pain from day 1 through 7. So we will still have another analysis on pain experience in the long term, which is days 14 and 21. And we'll try to see if there is any association there, but at least until day 7, we did not see anything.
Okay, and I would like to give you a few minutes to say goodbye. And I would like to thank everybody here on the behalf of the National Dental PBRN. Dr. Tungare, you have any last words with this group?
Oh, thank you very much to all the practitioners who helped us conduct this study, recruit all those patients, be actively engaged in the care, and utilizing the platform. So thank you to everyone. Thank you to the National Dental PBRN platform, of course. We couldn't have done this without them. You are incredible and provide so much support throughout. So we are really grateful. And of course, NIDCR for their funding. So thanks to all and our excellent research team and the NDPBRN team. that made
Thank
this possible.
you. Thank you, Dr. Tungare. Dr. Walji, what do you have for us? Any next steps with this huge study that you did? I know you're excited with all the publications and the data analysis.
Yeah.
What is next?
Yeah, no, absolutely. So one thing I will say is that we love hearing from practitioners about the research questions that you may have of this data. So, one thing we're going to do is make this data set available to others. So if you're a researcher, you're going to be able to analyze the data set, in different ways yourself. But if you have any specific research questions, please let us know. We'd love to explore that with you, have you participate on scholarly activities, publications, etc. We'd really love that. In terms of next steps, what we would really love to do, it seems like we can focus on different types of procedures. It seems like the higher level pain procedures, are some of those surgical extractions, etc. And we think there's an opportunity to, as Dr. Loomer mentioned, test out the benefits of this kind of approach of getting feedback from the patient regarding their pain, sending that back to the dentist, and see, can we actually improve on various health outcomes based on that? So we're very interested in potentially doing some sort of randomized controlled study. Now we know how this application works, or this type of approach. So that's probably one area that we will be looking towards in the future.
Thank you, Dr. Walji, and thank you for mentioning the opportunity to be using this data set and participating in scholarly activities, because we would like to encourage our members to be involved like that. You can go to nationaldpbrn.org and you can see the protocol there and all the data that was collected, the data forms. So you can generate some ideas and you can email us or Dr. Walji, but you can email nationaldpbrn@uab.edu. And we will direct your questions and your suggestions to Dr. Walji, and he will reach out to you to work collaboratively on answering those questions and conducting scholarly activities. Thank you so much, everyone who joined today. It was a very interesting webinar. I learned a lot. I was very curious about the data and looking at the results. We put so much work in collecting the data that we really appreciate when we can share the results with our members. And Dr. Walji, Dr. Tungare, I really appreciate your participation here, as well as Dr. Shirodkar and Dr. Loomer. Thank you very much, everyone.